السلام عليكم. راح نكمل محاضرتنا Genetic Disorder Dysplasia and Malformation. Genetic disorders, dysplasia and malformations. Chromosomes and genes. In the nucleus of any cells in the body, there are chromosomes. The chromosomes are a molecule of DNA, deoxyribonucleic acid. In the human beings, there are 8 cells contain 46 chromosomes. 44 of them is called autosomal chromosomes and 2 sex chromosomes. The part of the DNA that is responsible for transformation of a criteria from the father or from the parents to their sons called the gene. And each gene located in a certain place in a certain chromosome. This is called the locus. We have 2 pairs of genes that transmit the same criteria, one from the parent and one from the father and the other from the mother. So these genes called alleles. If these alleles are transmitting same criteria, we call it homozygous. If they transmit a different criteria, we call it heterozygous. The total the genotype is the composition of the total composition of the genes, and the phenotype is the expression of those genes. HLA is the human leukocyte antigen or major histocompatibility complex. This is a group of genes located on chromosome 6, and they code the immunity for the body. Genetic mutation. Each gene may cause mutation by changing of the nucleotide or deletion of part of it or insertion adding part of it. Genetic mutation sometimes useful and sometimes is lethal. Single gene disorder when the abnormality results from one gene. Chromosomes disorders, this result from either duplication of the chromosomes, extra piece of a chromosome, or extra chromosome, or deletion of a chromosome, part of it, or total absence of a chromosome. Sometimes there is polygenic and multifactorial disorders, like in case of gout. Patient had uricemia, and there should be the patient had hyperuricemia, and there should be an initiating factor like a trauma. Also, there must be some genetic predisposition. Embryonal damage, this results from damage of the embryo due to radiation, chemical substances, or drugs. Patterns of inheritance. We have autosomal dominant and autosomal recessive. The abnormal genes are located in autosomal chromosome, and one of the autosomal chromosome. In case of autosomal dominant, only one gene is enough to create the abnormality. So if one of the parents is affected, 50% of his children of either sexes will be involved, like multiple epiphyseal dysplasia. In autosomal recessive, the both pair of genes, both alleles, should be affected so that the problem transmitted to the children. So the mother and the father, both of them are carrier, and they will transmit the genetic problem to one of their sons. They will be affected. 50%, quarter of their sons will be affected. 50% will be carrier, and 20 and quarter of them will be normal. And X-linked dominant and X-linked recessive, the abnormality located in X chromosome. So if in case of dominant, only one chromosome affected is enough to transmit the disease. So in case of hypophosphatemic rickets, for example, if the mother had the disease, she will transmit the disease to half of her children. If the father is affected, he will transmit the disease to 25% of his children, and this explains why X-linked dominant is more common in female. X-linked recessive, in this condition, like in case of hemophilia, the mother should be the father, if he had the disease, he will transmit it to his daughter. His daughter will become a carrier. When she marries, she will transmit the disease to one of her children, who will become a bleeder, and one of her daughter will be carrier, and the other are normal. So 25%, 50% of her sons are affected, and 50% of her daughters are carrier. Classification, genetics disorder of cartilage and bone growth, chondral osteodystrophy. This condition, the abnormality located in either in the epiphysis or in the metaphysis or in the diaphysis, or the condition caused by collagen disease like osteogenesis imperfecta, or enzyme defect, and lastly due to chromosomal disorder. Multiple epiphyseal dysplasia. This is autosomal dominant inheritance. Usually the abnormality located in the epiphysis, and the baby will become short, but their faces are normal, and they can pass to adult life. They have in the future osteoarthritis. As you can see here, that the epiphysis is abnormally grown and it is flat in the condyle of the femur are flat, and the head of the femur is abnormal in shape, just like Pathy's disease. Vertebrae are normal. The vertebral shape are normal. And in the future, you can see the joint is incongruent and it may lead to osteoarthritis. So multiple epiphyseal dysplasia is a condition occurs in the growth of epiphysis. Treatment: joint replacement and corrective osteotomy in need. Spondylar epiphyseal dysplasia. This is a condition in which there is a multiple epiphyseal dysplasia plus vertebral changes. So there will be delayed ossification, flattening of the vertebral body, plateau spondyly, irregular ossification of the ring epiphysis, and indentation of the end plane. The mildest of these disorders is indistinguishable from multiple epiphyseal dysplasia. The more severe form have characteristic appearance. As you can see here, there will be kyphotic changes in the skull and the face of the patient. The patient is dwarf, and there is spinal column changes, kyphosis, scoliosis, and severe abnormality in the both hip joints. The vertebrae are flattened, what we call platyspondily. So this condition is multiple epiphyseal dysplasia plus vertebral column changes. Dysplasia with predominantly physical and metaphyseal changes, hereditary multiple exostosis. This is a common growth plate defect in modeling. The condition is autosomal dominant, and there is an exostosis, the characteristic exostosis, which we have discussed in lectures of tumors. Protuberance developed or outgrowth developed from the bone of the junction of the epiphysis with the metaphysis, and this protuberance will form a hard mass which may cause pain due to passage of the nerve and tendon nearby. And hereditary multiple exostosis, this exostosis will become multiple all over the body. The patient is short and there is multiple deformities, multiple masses all over his skeletal system, especially scapula and pelvis. The condition, if start to grow after the maturity of the bone, it indicates the possibility of changing to malignancy. So excision is advised. Achondroplasia. Achondroplasia usually inherited as autosomal dominant. In this condition, there is marked dwarfism, as you can see, the difference between these two babies. And there is a characteristic abnormality. The skull is large and the protruded frontal side. The nose is depressed and the back is affected. There is kyphosis or scoliosis, sometimes a combination of two conditions. Kyphoscoliosis occurs. There is excessive lordosis and the buttocks are protruded, and there is the dwarfism, the upper limb and lower limb. The proximal part is affected more than the distal part, as you can see in this baby. In X-ray, you can see the bones are short, but they are wide and usually deformed. And this condition can be diagnosed during intrauterine life by X-ray. And the most disabling problem is that the pedicle is short, and this will cause the spinal canal to be tight. And in this condition, nerve compression, spinal nerve compression, or cord compression could occur. Treatment, we have to treat the disability if it is present. Bone lengthening is not so much rewarding, and treatment of the spine because of the nerve compression by decompression is useful. Dyschondroplasia or foliar disease in chondromatosis. This is rare due to defective transformation of physical cartilage column into bone. No consistent inheritance pattern has been identified. There is short in one limb or one bone. Knee valgus or valgus and radius bend if ulna is involved. Hand may show multiple lesions and malignant transformation about 5%. As here you see the characteristic feature of foliar disease. There is striking of bone calcification, striking of calcification columns extending from the epiphysis to the metaphysis, and this is due to the ossified column of cartilage and the typical changes in the hand. Dysplasia with mainly diaphyseal changes. In this condition, dwarfing is not a feature. We have osteopetrosis standard and osteopetrosis congenital. In osteopetrosis standard, this is a common, usually benign condition, autosomal dominant, that seldom causes symptom. Shape and function are unimpaired unless there is some complication. What are the complications? Pathological fracture or cranial nerve compression, bone infection, particularly of the mandible upper tooth extraction. X-ray show increase in the bone density, as you can see here, and the cortices are very thick, medullary cavity are narrow, and sclerotic vertebrae will produce a characteristic appearance, a stripped appearance. We call it football jersey spine. The skull thickened and the base density sclerotic may carry the risk of pulmonary occlusion, cranial nerve entrapment. Treatment is required only if complications occur. Osteopetrosis congenital. This is rare autosomal recessive and presented at birth and causes severe disability. Bone encroachment on marrow result in pancytopenia, hemolysis, anemia, and hepatosplenomegaly. and this is because there is no space for growth of the bone marrow. Foraminal occlusion may cause optic or facial nerve palsy. Osteomyelitis, where tooth extraction or internal fixation of a fracture is quite common. Repeated hemorrhage or infection usually lead to death in early childhood. Treatment has been focused on method of enhancing bone resorption and hematopoiesis by transplanting bone marrow from normal donor and long-time treatment with gamma interference. Generalized joint laxity. This can occur in 5% of normal people, usually familial and autosomal dominant. They may have congenital dislocation of hip or shoulder dislocation and joint pain plus ankle sprain. To diagnose those people, we have what Brighton square. If somebody had 5 score, he may have this condition, and this includes excessive hyperfixation of the metacarpal phalangeal joint beyond 90 degrees. We give him 2. Passive stretching of the thumb to touch the radial border. We give him 2. Hyperextension of the elbow. 2. Hyperextension of the knee. As you can see here, we give him 2. Ability to bend forward and place the hand flat on the floor with the knee held perfectly straight. We give him 1. Ehlers-Danlos is a group of disorder characterized by joint hypermobility, skin laxity, and blood vessel fragility. There are more than 10 types of Ehlers-Danlos. Most of them are autosomal dominant. The classic form, type 1 and 2, which represent about 80% of the cases, usually the patient had abnormal skin and joint hypermobility and blood vessels abnormally fragile. In type 3, there is normal skin, but there is joint laxity. Type 4, there is blood vessels and internal organ abnormal bleeding may cause, and the joints and skin are normal. And there are other subtypes. In conclusion, Ehlers-Danlos is a condition that the patient may have joint hypermobility, skin laxity, and blood vessel fragility. Management. The possibility of dislocation is quite common, and reconstruction by soft tissue usually show failure. And we have to take care about soft tissue because there is failure of healing of the skin and the blood vessel because of the possibility of severe bleeding. Do you know a famous person with Ehlers-Danlos syndrome? Some believes that Michael Jackson had Ehlers-Danlos syndrome. Marfan syndrome. This is generalized autosomal dominant disorder affecting the bone, joint, ligaments, eyes, and cardiovascular structure. It is thought to be due to a cross-linked defect in collagen and elastin. Clinical feature: usually the patient is tall with disproportionate long leg and arm, typically arm span exceed the height. The digits are unusually long, giving what we call archnodactyly or spider finger. Spinal abnormality include spondylolisthesis and scoliosis. There is increased incidence of split upper femoral epiphysis, generalized joint laxity is usually, and patient may develop flat feet or dislocation of patella and shoulder. Associated abnormality include high arched palate, hernia, dislocation, retinal detachment, aortic aneurysm, and mitral or aortic incompetence. Management: patient occasionally need treatment for progressive scoliosis or flat feet. The heart should be carefully inspected. As you can see here, this is a patient with Marfan syndrome, and the span more than is high. He had arachnodactyly, and there is long legs and hands. Chest has rectus excavatum. Heart had problems, the aneurysm of the aorta, dilatation of the aorta, incompetence of the mitral or aortic valve, high arch, high palate arch, the recurrent dislocation of shoulder and patella, flat feet, hernia may be developed, scoliosis, and dislocation of the lens with retinal detachment. This is President Abraham Lincoln, and some believe that this man had Marfan syndrome. Do you know a famous person with Marfan syndrome? Yes, some believes that Mr. Obama had Marfan syndrome. Collagen disease, osteogenesis imperfecta. This is a common condition, 1 in 20,000 of them. This group of conditions have the following criteria. All of them has osteopenia, liable for fracture, with joint laxity. 2/3 of the cases had blue sclera, and 1/2 of the patient had crumbling teeth, odontogenesis imperfecta. The types, the mild type, which is autosomal dominant, in which the baby will have repeated fracture, and usually this disappears at the age of puberty. Lethal, which is a recessive form, the baby will have fractures even during intrauterine life. Severe deforming, which is the classical form, the baby will have recurrent fractures, especially even in the first day of his life during delivery. And he will have multiple joint deformities because of the fracture and generalized joint laxity. As you can see here, the bones are bent, osteopenic, and we call it warrior bones. The spine may have compression and causing spinal cord or spinal nerve compression. And moderately severe form, and this is just like mild form, but the sclera is normal. Treatment: gentle nursing, splintage, mobilization, and correction of deformities. Neurofibromatosis. This is a common single gene disorder. There are multiple types of neurofibromatosis. Neurofibromatosis 1 1 in 3,500 live birth defect. This is due to gene coding neurofibromine antichromosome 17, which is 100% penetrance autosomal dominant. Neurofibromatoma, Schwann cell, less common, show this multiple tumor-like lesion involving this skin, and this is the plexiform type with skin pigmentation. Usually the patient will have scoliosis. As you can see, the spine is bending and sometimes presented with pseudoarthrosis of the tibia. This is the classical cafe or the appearance of the skin. Malignant transformation is possible. Metabolic disorder, mucopolysaccharidosis. This is due to defect in the enzyme responsible for the metabolism of glycosaminoglycan, so it will accumulate in the reticuloendothelial system, usually presented as autosomal recessive, and the child born normally, but within the first 2-3 years, he will have delayed walking and increase in the kyphosis, and there is a protruding of the sternum. The spine shows plateau spondyly. The vertebrae are flat, and there is odontoid hypoplasia. Joint hyperlaxity also is another criteria, and there are many types of and subtypes of this problem. Treatment by enzyme replacement and treatment of orthopedic problems if it is cause severe symptoms. Gaucher disease. This is a genetic disorder described by Gaucher over 100 years ago. It's caused by lack of a specific enzyme that is responsible for the breakdown of the and excretion of cell membrane product from defunct cells. This is a classic example of fluid storage disease with secondary effect on bone. When cell die, glycocerebrocytes is released from the cell membrane before it can be excreted. The glycoside band hold the glucose molecule has to be split by a specific enzyme, beta-glucosidase. If the enzyme is lacking, the glycocerebrocytes cannot be excreted, and instead it is stored in the lysosomal bodies of the macrophages of the reticuloendothelial system, notably in the mono, spleen, liver. Accumulation of these abnormal macrophages lead to enlargement of the spleen, liver, and secondary changes in the marrow and bone. Like other storage disease, Gaucher disease is transmitted as an autosomal recessive trait. Most patients suffer from a chronic form of the disorder with changes predominantly in the marrow, bone, spleen, and varying degree of pancytopenia. Clinical feature: children usually presented with pain, sometimes loss of movement. In one of the larger joint, the spleen may be enlarged, or it may already have been removed. Older patients may develop back pain due to vertebral osteopenia and compression fracture. femoral neck fracture are also occurs, and elevation of serum acid phosphatase level is a suggestive finding. Common complication is osteonecrosis of the femoral head. The patient may present with acute bone crisis, severe pain, local tenderness, and restriction of the movement accompanied by pyrexia, leukocytosis, and increased ESR. The clinical feature resemble those of acute osteomyelitis. Imaging. X-ray may show distinctive feature of an expanding distal half of the femur, so-called Erlenmeyer flask appearance. Typical sign of osteonecrosis sometimes appear in the femoral head, femoral condyles, talus, and femoral head. Radioisotope scanning to distinguish crisis episodes, and magnetic resonance imaging to diagnose the bone marrow involvement. Gaucher disease can lead to osteomyelitis. Treatment. Bone pain may need symptomatic treatment. For acute crisis, analgesia, bed rest, and period of non-weight bearing is recommended. Specific therapy is available by replacement of the defective enzyme. Osteonecrosis is treated according to the guideline in the osteonecrosis lecture. You can see the expansion here of the distal femur, giving the appearance of Erlenmeyer flask appearance. The head of the femur show marked osteonecrosis and flattening with sclerotic change. In the MRI, you can see the presence of the accumulation of the byproduct and macroproduct of the reticular endothelial system. Down syndrome. This condition results from having an extra copy of chromosome 21. It is much more common than any other skeletal dysplasia, with an overall incidence of 1 in 800 members and 1 in 250 if the mother over 37 years of age. Affected infant can be recognized at birth. The head is shortened and the eye slant upward. Prominent epicanthal fold, the nose flattened, the lips are parted, and the tongue protruding. They may be abnormal palmar crease, endodactyly, and spreading of the first and second toe. The babies are unusually floppy, hypotonic, and skeletal development is delayed. Children are short, and because of their characteristic facial appearance, they tend to resemble each other. They show varying degree of learning difficulty, joint laxity, lead to sprains or subluxation, especially pattern. Associated anomalies, particularly cardiac defect, are common, and there is diminished resistance to infection. The average life expectancy about 50 years. There is no specific treatment, but surgery can offer considerable cosmetic improvement. antenatal care will allow many of these individuals to pursue a pleasant and productive life. Localized malformation, vertebral anomalies, agenesis, where there is complete absence of one or more of the vertebrae, dysgenesis, error of the segmentation causing hemivertebrae with or without vertebral fused together, and dysraphism, deficiencies of the neural arch, e.g. spinal bifida. Associated visceral abnormality, lower intestinal and urogenital defect are common in sacral agenesis and dysraphism, and other abnormality according to the area. Limb anomalies, pseudoarthrosis of the clavicle, transverse deficiency of the arm, radial deficiency where there is absence of the radial bone, proximal femoral dysplasia, the proximal part of the femur is underdeveloped and show marked shortening, tibial deficiency when there is a possibility of congenital pseudoarthrosis of the tibia, which is sometimes difficult to heal and need frequent surgery and bone grafting. Thank you and have a nice day.
Thank you very much. We will take rest for 10 minutes and we will continue. Okay, now we will choose a very short lecture. راح نختار إنه محاضرة صغيرة لأن أكيد أنتم تعبتوا. فنبدأ بهاي المحاضرة. الأسبوع القادم إحنا محتاجين يعني يوم الأحد أو الاثنين حتى نكمل محاضراتنا، لأنه عندنا بعض المحاضرات على الريجنال أورثوبيديك اللي هي الشولدر، الإلبو، الريست، هاند، بعد ما أخذناها. فإذا الأسبوع القادم إن شاء الله يوم الأحد نحاول أن نكمل، وإذا ما كملنا على يوم الاثنين. إضافة إلى المحاضرة اللي في هذا اليوم المفروض اللي هي الاندوكراين أيضا راح تتأجل على الأسبوع القادم، لأنه شوية الكهرباء فيها مشكلة ظاهرة اليوم. أوكي.
Osteonecrosis and osteochondritis. Osteonecrosis, aseptic bone death due to severeness of the blood supply or cell damage. Osteochondritis is bone necrosis following trauma to the articular surface. The best example of a vascular necrosis is fractured femoral neck that causing a large segment of femoral head which become necrotic and get a vascular necrosis. The common sites for a vascular necrosis are the femoral head, femoral condyle, head of the humerus, talus, and proximal part of the scaphoid. Why this occurs? All those bones we have mentioned before have the following criteria. All of them are outskirts of blood supply. They are covered with articular cartilage, and the arterioles are end-type arterioles. They supply with sinusoid. Sinusoid, as you know, had no adventitia, only one layer of endothelium. So whenever there is a pressure from surrounding structures, those sinusoid will become closed. In case of vascular stasis, case of hemorrhage, moral swelling. Capillary occlusion lead to edema and inflammation because of ischemia, and the bone marrow will swell. This will increase intraosseous pressure. Increase intraosseous pressure will cause more sinusoid to be occluded again, and this is a vicious cycle. So the most important thing is intraosseous pressure. The process of increasing intraosseous pressure may be initiated by several ways. First, severance of blood supply, venous stasis, intravascular thrombosis, compression of capillary and sinusoid because of swelling of the bone marrow, whatever the cause, and usually this is a combination of factors that will lead to osteonecrosis. Condition associated with non-traumatic osteonecrosis, hypercortisolemia due to cortisone administration or Cushing syndrome, hyperlipidemia, alcohol abuse, hemoglobinopathies, sickle cell anemia, capillary occlusion, dysbaric osteonecrosis, marrow inflammation and marrow infiltration like Gaucher disease, malignant disease, infection, and other conditions like Perthes disease, SLE, and clotting disorders. Pathology. Following avascular necrosis, we will have dead and living bones. What is the difference between dead and living bones? From structural point of view, there is no difference between dead and living bones. But the dead bone cannot renew itself, so it cannot tolerate stresses that occur following daily activities. We have 4 stages in the pathology of dead bone in case of avascular necrosis. First stage is bone death without structural changes. Usually this occurs after 48 hours of the severance of the blood supply. Stage 2, there is a stage of repair and early structural failure. In this stage, the bone tries to replace the dead bone with a new bone. But from structural point of view, the structure of the bone will be maintained. Stage 3, there will be major structural failure because the dead bone cannot tolerate the stress supplied by the body. Stage 4, after the structural failure of the bone, the articular cartilage, which is supported by the bone, will be destroyed. So there will be an articular destruction. Cartilage damage is not due to lack of blood supply. Cartilage damage is due to lack of mechanical support. Clinical feature. The lesion should be advanced before any clinical feature appears. Usually, pain and stiffness, local tenderness, and restriction of movement. X-ray finding. There will be an increase in the bone density. Why there is increased bone density? This not because that the dead bone is more dense than living bone. No, it is because of the living bone try to form a bone to compensate for dead bone. So this will appear as dense area because new bone trabeculae will become above the old bone dead trabeculae, and this gives this increased bone density. And with the time, with the possibility of bone collapse, there will be subarticular fracturing, and this will appear as a crescent-like fracture, just subarticular in the subarticular bone. The X-ray finding usually appear late. That means osteonecrosis has started and X-ray finding maybe appear months after the pathology starts. So the best way of diagnosis the avascular necrosis is by doing MRI, which the condition will appear very, very early, within the first 48 hours. Radionuclide scanning will show cold area due to lack of the radionuclide absorption in those areas. Diagnosis of the underlying disorder is very important, like whether it is caused by trauma, occupation, Gaucher disease, sickle cell anemia, corticosteroid, etc., etc. Treatment according to the stage. That is me. We have before or after collapse or advanced. Before collapse, before the bone still contain its original structure. So the treatment will be relief of the stress on that bone, and if there is increased intraosseous pressure, we have to do decompression of the intraosseous pressure, decompression of the bone. And we have to treat the cause. If there is collapse, if the collapse involve only a part of the articular surface, we can do osteotomy in order to shift the stress away from the involved area. If the osteonecrosis is advanced and the articular cartilage is destroyed, in this condition, the treatment will be the same of the osteoarthritis. That is, pain relief, exercises, decrease the stress, and erythrodesis or erythroplasty.
Muscular necrosis, post-traumatic. Usually this occurs in the femoral head, carpal bones, and talus. You can see here, this is the femur, and this is the lunate bone, and the talus. Treatment according to the previous slide.
Sickle cell disease. This is a genetic autosomal recessive disorder limited to people of black descent, Central and West Africa descents. In Iraq, we have many cases in Basra Governorate in Zubair district. The red cells contain abnormal hemoglobin, hemoglobin S, which become distorted and sickle shape. This is especially likely to occur with hypoxia, like under anesthesia, or extreme cold. Clumping of the sickle-shaped cells causing diminished capillary flow and repeated episode of pain, bone crisis, or the more severe ischemic necrosis. Almost any bone may be involved, and there is tendency for the infection to occur in the bone, in the infected bone, sometimes with unusual microorganisms like the salmonella. X-ray will show the trabecular bone, including phalanges, show irregular endosteal destruction and medullary sclerosis together with periosteal and new bone formation. This is just like osteomyelitis. And don't forget that infection with the infarction might become together. In children, femoral head necrosis should be differentiated from pelvis disease. The treatment, acute episodes are treated in rest and analgesia, followed by physiotherapy to minimize the stiffness. Established cases are treated according to the to what we have mentioned before, according to the degree of collapse. We have to take care for those patients when we give them anesthesia because of the possibility of occlusion in the central nervous system, lung, kidneys, and there is high chance for post-operative infection.
We have discussed Gaucher disease previously.
Drug-induced necrosis, corticosteroids and alcohol, both of them causing fatty changes, and this will lead to moral infarct. Besides head of the humerus, head of the femur, and condyles of the femur. Usually the symptoms are pain, and the symptoms will appear long time before X-ray changes appear. So MRI is the best way to diagnose this condition. Treatment, early changes, if not actually reversible, can be prevented from expanding by stopping the steroids and alcohol. Analgesics, weight relief, and physiotherapy are often that are required. Decompression of the affected bone by drilling may relieve symptoms and even prevent progressive changes in very early cases. If the joint surface has collapsed, reconstructive surgery is required. Osteochondritis or osteochondrosis is a group of conditions that share the following criteria. That is compression, fragmentation, separation of a small segment of bone at its ends with attached articular cartilage. The affected segment will show features of ischemic necrosis, that is increased vascularity and reactive sclerosis. This is occur in face of rapid bone growth and increased physical activity in adolescents. The causes is trauma and repeat stress. This trauma and repeated stresses will cause a very faint fracture of subarticular bone with the cartilage covering it, and this failed to unite and not appear on the X-ray. With the time will give this criteria. There are three types of osteochondritis. Shearing osteochondritis, osteochondritis dissecans. Small fragment of articular cartilage with the bone under it will separated as an avascular fragment. This is due to repeated minor trauma, causing osteochondral fracture of the convex joint surface. Occurs especially in nail and especially in the knee and the lateral aspect of the medial condyle of the femur. Presented with intermittent pain, swelling, joint effusion, and locking when completely detached. Imaging, usually in the X-ray, it will show a small fragment of the bone fracture if it is not separated. If it is separated, it will appear as a loose body. Usually, X-ray is too late for diagnosis. MRI is very helpful. Treatment, when it is still in the place, not separated, there is a place for fixation of that piece or conservative treatment by POP. If it is detached, there are two options: either removal of that part or refix it in place with the drilling of the subchondral bone because of the sclerosis and bone grafting. Crushing osteochondritis. This is occurred in adolescents, spontaneous necrosis of the ossific nucleus of the long bone and cuboidal bones of the hand and foot. Clinical feature: tenderness is sharply localized to the site of the involved bone. X-ray, there is decreased bone density, and later on the bone will collapse and its shape will be distorted. And the next slide will show some examples, and the treatment, usually conservative treatment. If the bone shape changed, there might be need for surgery by erythrodesis or replacement. Kind of disease: osteochondrosis of the unit bone, fiber disease, osteochondrosis of the ossific nucleus of the second metatarsal hair, palmar disease, osteochondritis of the capitella, and collar disease, osteochondritis of the navicular bone. Pulling osteochondritis, traction apophysitis, excessive pull by a large tendon of a strong muscle may damage the infused apophysis to which it is attached. Is it really necrosis? No, it is not a necrosis. It is just a traction of the apophysis that is attached to the bone, and attached to the tendon, so that the apophysis will respond by forming a new bone, and this new bone is somewhat tender because of the vascular response. Treatment by rest and analgesia. Examples for pulling osteochondritis: Musculo-skeletal disease, apophysitis of the tendon, of the patellar tendon, the tibial tuberosity, because the patellar tendon attached to the patella and patella attached to the quadriceps muscle, and this will cause swelling and tenderness in the area of tibial tuberosity. Another example is Sever's disease. Sever's disease usually causing traction apophysitis of the apophysis of the calcaneum due to the traction of tendon Achilles, which is attached to the gastrocnemius muscles, and this condition occurs in young age boys, mainly at age of 13 to 15 years old, and always they participate in sports. They have severe pain in their calcaneum. Rest and some analgesia is quite enough.
Thank you very much for listening. حقيقة اليوم نكتفي بهذا القدر، عندنا ظاهر مشكلة بالكهرباء فأشكر حضوركم للمحاضرة. أشكر الطلاب اللي شاركوا ويانا، عمار، علي، ياسمين. والمحاضرات راح تلقوها موجودة إن شاء الله بالمرحلة، بثناها على منصة الكلاس روم. الأسبوع القادم إن شاء الله يوم الأحد نكمل باقي المحاضرات. بس أريد منكم أنه ما تنسون أكو ترى داخل المحاضرات أكو كويزات، وأتمنى أن تجاوبوها حتى نحسبها مشاركة لكم. أكو أحد عنده سؤال؟ إذا ما عندكم شيء أخذوا راحتكم. شكرا جزيلا.